Welcome everyone to ClearPoint On Demand. I'm Kara Kittleberger, the Director of Education, and today I'm delighted to introduce our panelists from the neurosurgical team at the Brigham and Women's Hospital in Boston. Dr. Rees Cosgrove is an expert in stereotactic and functional neurosurgery with over 30 years of experience in the field. He is currently the Director of Epilepsy and Functional Neurosurgery at the Brigham and the Harvard Medical School Neurosurgery Residency Program Director. He has personally performed nearly 250 MRI-guided surgical procedures using ClearPoint for a broad spectrum of surgical approaches to movement disorders, epilepsy, and other conditions. To walk us through the anesthesiology side of MRI-guided procedures, Dr. Dennis McNicholl will draw on his nearly 20 years of experience in practice. Dr. McNicholl has been an integral part of the Brigham's anesthesiology team, supporting MRI-guided procedures since their adoption of this technology in 2015. While our panelists today will be speaking from their personal experiences, they are also part of larger teams at the Brigham, which include 5 practicing neurosurgeons from different specialties who have all utilized ClearPoint in their practice. When a procedure has called for prone positioning, the techniques we will discuss here today would have been used. With that, please join me in welcoming Dr. Cosgrove and Dr. McNicholl.
All right, so welcome everyone. I'm going to give an overview from the neurosurgeon's perspective about what the goals of these different procedures are when we have to use prone positioning. And then Dennis will provide a lot more detail about the anesthetic considerations. So I'm going to describe the neurosurgical goals first, and then Dennis will follow with the anesthesia goals. And here are the disclaimers. I actually, I am a consultant for ClearPoint Neuro, so you can take everything I say with a grain of salt, but I'm convinced that this is a great way of performing these procedures. So my most common utilization of the prone procedure is with laser ablation in patients with intractable epilepsy, where we are attempting to ablate the mesial temporal lobe. But there are a number of other indications where you may need to use prone positioning. This could be true in laser ablation of a tumor where you'd get better coverage of the lesion with a posterior approach, and also in the evolving field of gene therapy, where it may be advantageous to do a single trajectory, possibly into the basal ganglia, putamen or otherwise. So those are the times where you may want to use a posterior approach, which would by definition then require the prone position. So I've broken it down into a whole bunch of different steps to outline the workflow. I am always really happy when I see Dennis in my operating room, because then I know the anesthesia part at least is going to go smoothly, and you'll hear his expertise when he shares. But so the first step, obviously, patients placed under general anesthesia. We do that in outside our MRI suite, and after the patient is under anesthesia, we turn the head and shave the appropriate side. You have to shave an area big enough to allow placement of the grid, which I'll show you later. We do use, because we're using a laser, even though it's inside the head, our hospital wants us to put in eye protectors, and it's not so useful for that. I think it's sort of silly, but it is useful then for placing the frame, because these have firm protectors so that the sharp points of the head ring won't accidentally hit the eye. So we place the head ring first in after induction, and I tend to just place it in roughly a neutral position you multiple options about placing these posts and the length of the posts. But for at least laser ablation, the mesial temporal lobe, I place it roughly in a neutral position, make sure it's very secure, and then you can proceed to wheeling the patient into the MRI suite. Here, that takes a small army of people to take them off the ventilator that is in this area, in the induction area, into the MRI suite. Once the patient is in the MRI suite, we flip the patient prone on bolsters, and then this the head fixation ring fits into the base, the ClearPoint base, which allows you to tilt the head probably 15 to 20 degrees to just optimize placement. We put our additional head MRI coils. In this instance, we are using 2 coils, and we just secure them to the frame with cloth tapes. After this, we do the standard prepping and draping. And then the next step is, and this is a important one, is to fix the fiducial grid onto the area that has been shaved. I staple all the drapes to the scalp, and I also staple the grid, because this grid has to remain conformal to the scalp. And once you have to check and make sure once the patient is retracted back into the center of the scanner that it hasn't elevated or flipped up in any way. Because then after our first MRI, where we localize with contrast, we choose the appropriate entry point and the appropriate target point. For the hippocampal ablation, I always, first and foremost, you try and avoid any veins or arteries on the surface, and then along the trajectory, trying to avoid sulci if possible. But the most important thing I try to do for the hippocampus is to stay under the ventricle. Don't really want to enter the ventricle, and then because that could distort the trajectory once it runs along the hippocampus. But so this we spend a fair amount of time on to choose the appropriate entry point, a safe trajectory, and the target. Once that has been selected, then the patient is pushed out through the top of the MRI scan. We attach the smart frame. I do a scalp mounted smart frame application in this instance. And then I think most people are familiar with the multiple imaging and corrections using the ClearPoint to get it perfectly aligned. Once we have it perfectly aligned, then the patient once again is brought out through the top of the scanner, and we have to drill we make a small incision, and then we drill through the ClearPoint device exactly on our entry point. This, of course, this I think is actually the weakest point process, because you have to drill very carefully. You have to steady your arm very carefully so that, number one, the point doesn't skate along the curvature of the spine. So I will often just hold my hand very carefully and do lots of turns and not press too hard at the beginning. We drill a smaller entry point first, and then a larger 4.2 craniostomy secondary, and penetrate the dura. And then we place the laser probe. Then the patient's withdrawn back into the MRI scanner. And of course, then we will confirm that the laser probe is on target. And then, of course, monitor as we perform laser ablations. We go to the most anterior point of our trajectory, ablate, withdraw, ablate, withdraw, ablate, withdraw, ablate to ablate the entire mesial portion of the temporal lobe. Once that has been completed, we withdraw the laser, put a stitch in the skin, take off the ClearPoint device, and awaken the patient. I think that's my last slide. Yes. So I will stop sharing those. Those are the briefly the workflow from my neurosurgical perspective. I will now turn it over to Dennis to talk about all the anesthetic considerations, which I never worry about because I have Dennis there, basically. Yeah. Thanks.
Thank you. So we'll get started here. Welcome to everybody this will cover the anesthesia part of these kinds of procedures. And I like doing these cases because they're a bit of a challenge. We've learned a lot over the years, and they are, I have my disclosures here, same as Dr. Cosgrove. You can read those. And then I look at this as a tale of two challenges, because really they come down to nuances of the prone position, doing procedures like this, which is not as common, clearly. A lot of learning to do about that, and also in the MRI environment. So I do a lot of prone cases in the main OR for neurosurgery, either for spine surgery or intracranial surgery in certain instances, and then also separately MRI environment for patients needing diagnostic imaging, or for these procedures based in the MRI. So it really is a crux of those two issues with the anesthesia and positioning and all the details we're going to get into. So this is where we're going to get to. This is the patient being prepared for the prone positioning. I'm going to come to more details about this, but this is right before this is the part right before going prone and going into the MRI. We'll revisit this slide and some other details about it shortly. The workflow, as Dr. Cosgrove mentioned, I'm going to reiterate with some little more detail because it's the preparation, a lot goes into the preparation to ensure a good outcome. We do the induction in the non-MRI environment because we have certain things that are not MRI safe, things that are ferromagnetic, which would not be useful to have in the MRI. The Foley catheter is placed out in the non-MRI environment. It has a metal clip on it, which we remove and replace with plastic clips. The head shaving device obviously is not it is ferromagnetic, so that has to be done outside as well. And additional IV placements, since we usually have invariably have at least 2 IVs, and trying to place another IV in the MRI room has some issues because the stylets or the needles for the IVs are ferromagnetic, so there's a bit of a pull to those. We try to avoid any line placement in the MRI suite itself. Once the patient's positioned, I'll go over much more about how the patient's prepped after intubation, but the next part of the workflow is transferring the patient into the MRI room on an MRI safe stretcher. And then we'll go into the prone position. In this case, the pins are all placed in the non-MRI environment. There's other cases that we do prone where additional pins are secured to the head in the MRI, which they're already there. And then we'll do, once everyone's ready and all the lines are in good place, we'll position the patient at the isocenter of the MRI. So their head is in the middle of the bore of the MRI. And we'll do an initial scan to get everyone's bearings. And then further positioning for surgery is the actual position for surgery is with the patient's body entirely inside the MRI bore, and the head is out the other end of the MRI bore, so they can do surgery there. At the conclusion of surgery, we reverse these prior steps, reverse muscle relaxants, and do emergence or extubation, typically in the MRI room. However, if there were issues with intubation, requiring glide scope, et cetera, or any kind of video scope, we will keep the patient intubated, go back to the non-MRI environment room, which is adjacent, immediately adjacent, and do the extubation in that setting. So the going to sleep part, if there is any issues with intubation or any concerns we have with the airway, we do those out there as well. So we'll begin with the end in mind. We have a couple of rules we like to follow. Usually this is an edict from the surgeons, and first one is the patient cannot move. The precision with which this device is used is fairly incredible, down to fractions of a millimeter. So it's essential the patient doesn't move. That's the first rule. And the second rule is somewhat similar. Also, the patient can't move. And rule number 3 is the patient cannot move. So this gets reiterated to us, and it's understandable why that's the case, but we'll have some strategies to accomplish that. Another instance of or nuance to this type of procedure is that the access patient is severely limited. In pretty much all the other OR cases we do, we have some access to a limb, or if we have to check an IV or move a twitch monitor, we usually have that luxury. But that luxury is largely removed for this case. When during the middle of the procedure, for these procedures, the patient might come back, their head might come back to the ISO center of the magnet, giving us some access to the patient, but really still pretty limited. So that's why we want to get everything in good stead before we position the patient for final surgery. This is time well spent. We spent a lot of detail with this, but it's certainly anyone can do this. It's just more attention to detail. And just to reiterate, it can be done safely. And it's gratifying to get it to come out well. So we talked about patient movement, since this is such an important issue. Why do patients move under anesthesia? Light anesthesia, not uncommon. I should mention the surgical trespass for this procedure is pretty low, very low. They do, either a burr hole or just a pinhole incision for the surgical part of it, and then the brain being insensate is really not a surgical challenge in terms of pain management. However, patients still need some pain management. But light anesthesia is one reason the patient might move. Inadequate neuromuscular blockade, very important. So if neuromuscular blockade is going to be used, I'll spend some more time with this. It's a very important issue. It's important to get that correct. Other pain or surgical stimulation, usually this involves any kind of scalp manipulation. So Dr. Cosgrove seems very good at using a lot of local anesthesia, very generous with the local anesthesia, and that really decreases our requirements for pain management. Sometimes when patients get oropharyngeal secretions, in any case, this can make them cough, any kind of stimulation of the vocal cords. So managing that is another way around this. And then anytime there's an ET tube obstruction from mucus plug or circuit condensation, that can make them cough. Anything inside the tube or the lung that's making them want to cough. So here's some options for ensuring the patient doesn't move, different approaches to it. Using the depth of anesthesia, I'm not going to try to prescribe one way of doing this in terms of anesthesia, because a lot of people have different ideas about doing that, but in any case, the patient should be well anesthetized. Volatile anesthetics can do it on their own, or in some centers, total intravenous anesthesia is the way of the world. Sometimes we do a PIVO, which is partial intravenous anesthesia, using some volatile anesthetics as well as propofol infusion to augment that. So it's a bit of dealer's choice with that, and that's okay to do it that way. Pain control. The patient will need some pain control usually during, for intubation, and then also for the pin placement. We tend to use remifentanil infusions for those, but not always. And then pain control at the end is usually very light, if at all. So the local anesthesia is usually doing quite a good job. And sometimes we use intravenous Tylenol or acetaminophen, or as some people in Europe know, paracetamol. So again, this can be done various ways. I find the patients don't typically need big boluses of opioids during the procedure. And then another key option for using for preventing the patient from moving is with muscle relaxation. So in some cases, we'll use most cases, I'd say, intermittent boluses, or also continuous infusion. The only issue with the continuous infusion is that the lines for the infusions are pretty long, so you'd have to have a lot of muscle relaxant mixed up in order for it to get to the patient. So I find I use those more for cases where the lines aren't as long. So getting more into this detail about neuromuscular blockade, on our electronic health record, we can set a timer for redosing. It pops up on the screen saying to recheck or to redose the muscle relaxant. In some cases, empiric dosing might be okay, but I found that sometimes patient factors or the patient's metabolism might be higher or lower than what you expect. So we end up with too much or too little muscle relaxant. So again, I just mentioned about the continuous infusion versus boluses. We typically use boluses at a fairly short interval. Patients on anti-epileptic medications, as most anesthesiologists will know, they tend to metabolize these muscle relaxants fairly quickly. So that makes the usual redosing intervals a little more difficult to predict. So that's why it's good to follow these. The opposite occurs with renal insufficiency. People tend to hold on to those muscle relaxants that last longer for them. So adjustments for that can be made as well. So the question about train of 4 monitoring. So the train of 4 monitor, the Twitch monitor, is not, it's a ferromagnetic device. So getting it into the MRI will be dependent on what your local protocols are. We work very closely in our Amigo suite with all the same people all the time. And basically, I've never used the Twitch monitor myself in the MRI environment. However, I have someone else hold it. I'll show you pictures of that and how we do that. So that's the MRI technologist that will hold it. So I don't operate it myself, so I don't actually carry it into the room. I don't touch it. All I do is press the button to check the twitches. But periodic checking throughout the procedure really helps me know where the patient stands in terms of muscle relaxation. So it depends on if it's allowed or not allowed in your site, but I can tell you that we do it, and we've done it safely and haven't had the Twitch monitor get sucked into the magnet. The monitoring site, since the patient access is so limited, I'll show you one way around that, the way we have done it. Basically, we're using it on the posterior tibial nerve. Line placement preferences. This is a very important issue because with such limited access to the patient, you really need to know that your lines are working, they're secure, and they're not going to fail for any reason during the procedure. But once you apply some of these little techniques, though, it's usually should not be an issue. Mostly with continuity of the line. If you have an IV that looks, well, it's dripping or not dripping very well, there's something you want to correct beforehand. As I said, we use 2 IVs typically. The initial IV placement typically dorsum of the hand or the antecubital. The patient usually comes to us with that from the pre-op holding area. We typically use one of these lines for boluses. I like to plan my lines in advance based on where how the patient's going to be positioned. So when they're, and that's based on where our infusion pumps are located. So when the patient's in the prone position, their left side of their body is going to be closer to the pumps that we use. So I typically put the initial IV in the left side, left hand or antecubital. That's just a preference. It doesn't have to be that way, but it does make the lines go a lot easier. I'll say one thing about patients with ports. If they have very poor access, or that they only have a port, if they have a port that they can use and otherwise very difficult IV, then getting initial IV access with the port might be fine. However, in the prone position, ports are really could be problematic. There could be kind of shifting of the connection of the port, and just something that I wouldn't want to rely on heavily. So if they can get a peripheral IV instead, that would be better. If not, they can have the initial IV with the port, go to sleep with that, and then place additional IVs after that, and either pad that port for the procedure or remove the access to the port through the skin. But that does come up from time to time. A second IV we place afterwards, typically saphenous vein or a dorsal foot, and this one we use for continuous infusions. This is the best access we have to the patient, as you'll see from some of the pictures, and it's something you want to be able to monitor and know that, since you have several medications going through this IV, that it's going to be a reliable one. Patients with diabetes or any patients with poor wound healing, such as vascular disease, we can avoid that and put it either in the hand or the antecubital of another space, or if they just don't have a good saphenous vein, that's fine. So these are just general ideas or general considerations. If I had my preferences, this is where I'd do it. But again, we sometimes just have to get access wherever we can get it, and that's fine. Very important to have the lines taped out straight, no loops. I'll show you some pictures of this, and every anesthesiologist on this webinar will understand what I'm talking about when I show you that. But we want to avoid things during the procedure that will have to either truncate the surgery or cause them to have to stop and fiddle with a line. Those kinds of things, they're avoidable in my opinion, and something we can do some things beforehand to prevent. The infusion line connections we put as close to the IV cannula as possible, so that you decrease the dead space and make sure that they're tight. For any IV that you put in, you can make sure that they're super tight. Very important. Once the patient's in the scanner, you don't want to find out that there was a poor connection. If someone else placed the IV, sometimes frequently I'll just make sure that it is a tight connection. The blood pressure cuff placement is usually put on the contralateral arm, contralateral to the IV. Depending on the patient's body habitus and how they fit into the scanner, if they're thin, it's usually not an issue, but if they're obese or a wider body habitus, we don't want compression of the blood pressure cuff against the bore of the magnet. So in that case, we opt for the forearm instead. And again, when any part of the limb is conical, I usually tape it in place so that I know that it's in the same position for the whole case. One of the overall goals I'd have for this patient is however they go in, however they look when they go in, with all the lines and endotracheal tubes secured and blood pressure cuff, et cetera, they should come out looking the same way. So you shouldn't have migration of these things or pulling on things to disconnect them. They should look the same as they looked when they went in. So usually just taping that to the forearm is good. And then I usually use the endotracheal tube midline. I'll show you a picture of that and why we do that. So again, here's how a patient's IV is normally attached, but this is going to be a problem because as the patient goes into the scanner, their lines are going to be coming out back towards us. So the reason why looping it is a bad idea is that you can get this kind of situation, and all of a sudden you think your IV is not working when it actually is fine, and that kind of kinking is not well tolerated. So this kind of situation is much better. As the patient goes in away from us, then there's no kinking to worry about. Same thing with a foot IV, no loops on it. We'll avoid that kinking situation and just have it come straight out at us. This is just the connector we use, goes as close to the IV cannula as possible, and it allows infusions of several different medications with very minimal dead space. Very useful product. This is just the product packaging for it, but you can, as long as you can minimize that dead space, that'll be taken care of. Key aspects of airway management include which type of tube you're going to choose, how you secure it, and ensuring the continuity of the circuit. For prone cases, or any case where the patient's head might be flexed, you might be tempted to use an armored endotracheal tube, a reinforced or wire reinforced tube. That would be great. However, it's not allowed in the MRI, so that is not an option. So one way around that is to select the endotracheal tube so that it's less likely to have any kinks in it. This is just the packaging for a regular size 7.5 endotracheal tube, as measured by the internal diameter there. And then also we'll give you the outer diameter. The difference between these two is the wall thickness. So the idea here is that the wall thickness is going to protect you more from kinking of the endotracheal tube, especially any patient in the flex position. These patients for these procedures aren't overly flexed like you have for some other intracranial surgeries, but it's just one way to address this issue of kinking. As you can imagine, that would be a fairly catastrophic occurrence if it happened during surgery. This is just a table of different sizes of tubes and their outer and inner diameters with the wall thickness on the right-hand side. So you might get a 10 to 15% increase in the size of the thickness of the tube, and just to protect against kinking. So increasing the size of the tube that you choose. The downside obviously is maybe a little more sore throat, but I think the upside is well worth it to build in that level of safety. How we secure the tube, these are just two different kinds of tape. The pink tape on the left is a little more of a plastic texture to it, and there's regular, what we call silk tape on the right. Patients in the prone position, they tend to have secretions build up, and that comes out through their mouth, can get all over the tubing and the tape, thereby loosening the tape. Not a situation I really plan to entertain. So I choose the secretion resistant tape to address that slight issue. Works very well. There's it's what we call a corrugated connector, or a gooseneck connector, which we put in between the endotracheal tube and the anesthesia circuit. I'll show you why and how that's important with some more pictures, but this is very useful because it's our gateway to the rest of the trachea. These are gauze bite blocks that I make myself, very simple, out of gauze and wrapped with tape. They're about 3.5 inches long. I place those with a tongue depressor just over the tongue with the endotracheal tube midline. Because the patient's so far away from us, we need 2 lengths of carbon dioxide sampling tubing. So we have a connector here. This is a male-to-male connector that gets connected. The reason I mentioned this one in particular is that not infrequently it's underfoot because it's so long and has to get all the way to the anesthesia machine. So on occasion, if someone were to step on this, it would look like circuit disconnection or something more alarming. However, this would be one of the first places to look for an actual breach in the continuity. So it's an easy fix, but it's one of the things that we found can happen and can look more sinister than it actually is. This is a repeat of that picture that Dr. Cosgrove had. I should say, securing the head frame will come after this, but the eyes are taped typically, and very important for prone positioning for any length of case really is not to put any pressure on the eyeball. So I generally just put some Tegaderm very lightly but occlusively over the eyelids, and that should secure it for the rest of the case. Again, they should look the same when they come out as when they go in. So In this case, we also have this eye protector, very useful. The typical considerations for prone surgery regarding visual loss, that visual loss risk with prone surgery is really not as important, I should say, or they're not as common. Those risk factors that we have for postoperative visual loss, not really an issue for these surgeries because the length is much shorter. There's no real blood loss. Important to keep the patient's blood pressure at a reasonable level, though, which we do. I should say along those lines that nearly every patient needs blood pressure support in the form of some kind of vasopressor because they're under general anesthesia and they only have a certain level of stimulation. So typically a vasopressor infusion is pretty much required. And again, the goal is normal blood pressure for them. So as you can imagine from an airway management standpoint, this would not be a welcomed situation for an anesthesiologist to have to deal with. This frame is in place and it's bolted on. So removing this would take some time in a hurry if it was necessary. That's why we take all these precautions to try to avoid having to do any airway manipulation during the procedure. It's more of a theoretical question, rhetorical question. I know that every anesthesiologist here has had a circuit disconnection. So this is one case where you really want to avoid that, and attention to detail is really important. So we start by securing the tube really well, obviously verifying the tube position is in a good position above the carina. And the gauze bite block, as I showed, we secure that to the endotracheal tube. There's some umbilical tape that we use, just some cloth umbilical tape. We tie that to the tube and then I cut off the ends of it. So it's those ends aren't going to get caught on draping and so forth. The pilot balloon of the endotracheal tube is ferromagnetic, the spring in there. So we tape that to the tube. And then, as I mentioned earlier, upsizing the tube, it's a good choice, I believe, to get to avoid the kinking issue. And then this is where the gooseneck connector goes. Ensuring the continuity of the circuit, again, very important. This I do always myself. The connection between the endotracheal tube and the adapter at the top of the tube must be tight. There is a little trick you can use for that by removing the plastic part at the top, dabbing it with a little alcohol wipe and reinserting it. That helps to cement it there. I find that useful. That has to be a tight connection, so we're not going to be able to easily get to that. So if there was a disconnect there, that could be an issue. And then we connect that to the gooseneck. That also very tight. I do that myself and verify that. And then this one, this connection, I would say should be snug because this is where you're going to have the best access again to the airway if you need to do it. In those cases, it would be for something like endotracheal suctioning, removing the respiratory condensation from the gooseneck, or administering albuterol or anything through the endotracheal tube. So a snug connection there would be good. You don't want it too tight or else getting it off could be an issue when you might need to do that. So here we are back at this position where we brought the patient in, they've been prepared, they're under anesthesia. We transfer them over on 100% oxygen, and we're now ready to go prone. So the head frame slot is, I don't know if anyone can see my cursor, but it's right here. So the frame is going to go right into that slot. We do this in conjunction with the neurosurgeons. As you can see here, I have the IV on the patient's left hand, and there's another one in the left foot, so that when the patient goes prone, those will be on the near side of the bore of the MRI and closest to the pumps. The pumps are located here in the corner, so we have to have long lines that get all the way to the patient that way. The anesthesia machine is located close by as well. We notice the padding here. This is a chest padding located longitudinally. Also padding for the knees and for the lower legs with the pillow there. These pumps are actually in a Faraday cage, so they're okay to be in the MRI room as long as this door remains closed. this patient's body is going to be entirely inside the scanner, and the length of this bore of the MRI is 5 feet. So this patient's is about 5'5", or for our European colleagues, 165 centimeters. So they're basically going to be entirely encompassed in there. We do use a bear hugger to keep for temperature management, forced hot air blanket, which is has a long line connected to it, a long hose, and the machine for that, which is also ferromagnetic, is kept in another closet at the other end of the room inside the MRI. So this is kind of the padding we use for any areas such as IV connections, blood pressure tubing, any place we can find. This is just the opposite side of it, made by 3M. Blood pressure cuff tubing will be padded there. And then this is just another piece of foam. So if a patient has a port, or we really have to rely on the port, I do this little custom cutout job to protect it so that when the patient's prone, it will be won't cause any pressure source. Again, we try to avoid using ports during the procedure. So if you're going to focus your attention on anything, this is where I focus most of my attention, because this is where this is the one calamity you want trying to avoid, and getting the curvature of the tube as it comes out of the patient correct. This is the kind of the crux of my day. Once this part looks good, I feel a lot better. As you can see here, the tubing comes out. It should have a gentle curvature to it. It should not be pulling on anything. And you should be able to see it at all times. It should just look like a normal curvature. That's why I put it in the center of the mouth. And then from the other side, this is where it's reevaluated on this side, and then the tubing for the circuit comes up and over, and that's secured and padded as well. Very important to get that detail right. This is with the patient all the way at the other end of the bore of the magnet, so you can see what the surgeons are looking at, and our view would be quite different at the other end of the magnet. I do check once the patient goes back over that this is the only real access we'd have to the airway. As you can imagine, when the patient's draped, all the drapes are going in front of the bore of the magnet there. And I could get behind this, behind those drapes to get to this tube if I needed to. And that's why this connection here between the anesthesia circuit and the gooseneck is probably my best access to the tube if I needed to do an endotracheal suction. So that's why I just want to ensure that I have access to that, and it's just snug and not overly tight. Just another picture of where this access point would be, and that looks good. So this is basically what you can see, what we have access to the patient. We put these IV lines overhead so that nothing gets stepped on and having to readjust those during procedure. We call this the Tower of London approach to our IV lines. And for twitch monitor, this is the posterior tibial nerve for getting plantar flexion of the big toe to check twitches during the procedure. So how do we do that? This is how we've grown to check these during the case. So we'll bring the, I will not bring the twitch monitor in, but the MRI tech will. They hold it at all times. And I just put the wires onto the patient's electrodes, check the twitches, and then it gets removed. The twitch monitor and the wires get removed. They go out until we need them again. Standing in this position we found the best, because there's very little, if any, tug on the twitch monitor itself. So managing some patient comorbidities as it comes up, as I mentioned about anti-epileptic medication, either they should be on board for that. The procedures aren't excessively long, that really likely to miss a dosing interval, but important the patient's up to date on those. It can affect the metabolism of the muscle relaxants. Opioid tolerant patients, not a lot of changes to our management, since this is not a procedure that requires a lot of extra opioids. These ones are fairly important, though. Anyone who has a history of marijuana or vaping, or any patients with asthma or COPD, these patients, I do mention to them that the risks are higher with this because of the limited access. But if they need a pre-op neb, so be it. Sometimes if they are a heavy smoker, an endotracheal suction before going into the MRI might be indicated. Patients on ADHD medications just might have higher needs for anesthesia, higher requirements. And then again, renal insufficiency can affect some of the medications that we're giving, just to be not overdoing it with muscle relaxants. And obesity or morbid obesity, just basically fitting in the scanner and making sure that padding is well situated. In the MRI environment, the EKG is usually giving a signal, but it's not a very reliable signal in terms of ST segment monitoring. So that is also something I mentioned to someone who had that kind of a issue, that we can't really monitor that very well. It's just a natural consequence of the interference from the MRI. Just something to be aware of. Scenarios to be prepared for: airway compromise, as I've alluded to already. This, if it did occur, we'd have to have immediate head frame removal to manage the airway. Unlikely to be able to get even an oxygen face mask, circuit mask under that head frame. So knowing where the tool is to remove those pins immediately is paramount. Having someone there to do it is paramount. Temporizing oxygenation we can have some room to go up on the oxygenation during that time. And then if reintubation is required, we could do it in the MRI room, far enough from the magnet, with regular or our standard laryngoscope. But if you needed to do it with a videoscope, then it would require immediate removal to the patient. And then just always be mindful of allergic reactions. They'd be treated as normal for any other OR kind of case, but because of the nature of the patient being not very accessible, this would require more immediate removal to manage. And then CVA, I mentioned it, but it's extremely rare. This is our floor plan so the MRI is zone 4 and the outside MRI is zone 3. We actually put the patient to sleep typically in this operating room and come through these doors into the MRI, but there's also a kind of a crash area here in the MRI zone 3. The operating room here serves as our usual landing spot, but if everything's going fine, not to worry. If there's something happening, you have to get the patient out as fast as possible. That means having the MRI stretcher immediately available, the MRI safe stretcher immediately available to get the patient prone or supine back onto that bed and then back out. That's where you can manage that situation there and take the MRI considerations off the table. Delivery of oxygen, 100%. We use 4 transfers between the induction area and the MRI, and then it's kind of dealer's choice what you want to run out at that stage. If I typically use the lower FiO2, still more than what the patient's normally used to, but if there is going to be an issue, it will show up quicker with the lower FiO2. When you see capnogram changes, that should alert you to determine what's going on as fast as possible. Some kind of breathing pattern beyond which muscle relaxant hasn't taken care of. Reassess the neuromuscular blockade. Condensation in the circuit may show up in the plateau area of the capnogram. And then, as I mentioned, a false alarm CO2 sampling tubing, if it gets stepped on or cracked, then that can lead to a situation that's easily rectifiable, but you have to investigate that. And basically, you want the same capnogram for the whole procedure. So here we are with our summary of the modifications we have to the standard anesthesia workflows. I mentioned the specific details about line placement and why we do it that way. Ultimately, you have to get them where you want them, but make sure they're tight, they're well secured with tape and coming straight back out at you. I recommend increasing the size of the endotracheal tube just to improve the chances of not having a kink in the tube. And once you're secure and you have a good curvature to it, I think the day will get a lot easier. And then we use neuromuscular blockade. It's certainly possible to do it without neuromuscular blockade. Deep anesthesia with good blood pressure support is also a possibility. And then just attention to details, all of them, just to narrow it down. Thank you.
Thank you. That was wonderful. We already have a ton of questions, but if anyone has yet to submit a question in the chat, please go ahead. I'm going to kick us off to a question to both of you. If you had to choose between a supine position procedure that maybe would require multiple trajectories to get good coverage of a target versus a prone position where you could potentially get everything you need in one shot, would you have a preference on the patient position in that situation?
It would depend. It's always easier to do it supine, but I think it's sort of a neurosurgical decision or judgment about it depending on your target. Every time you, if you can do it in a single trajectory, I think it's optimal. So I think this question stems from some of the gene therapy protocols of targeting the putamen. And do you do 3 from the supine position? That's 3 separate plans, 3 separate trajectories, 3 times the risk of intracranial hemorrhage. So that I think I would choose prone with a single trajectory and 3 separate infusions of the biologic agent along the same trajectory. It'd be so much quicker.
Dr. McNicholl, any thoughts on that situation?
Well, whenever we would obviously prefer supine as well for a lot of reasons. There are other considerations of going prone or just removed. So, but to be honest, I think whatever the surgeon needs to accomplish what they need to accomplish, we're willing to do. I think that should trump everything.
That's why I love you, Dennis.
Okay, this is just for Dr. McNicholl. Can you discuss the decision considerations for using gas anesthesia versus TIVA? Is that primarily based on the length of procedure or something else?
Right. So I know myself and my colleagues, there's variation in how it's done. So I find gas to be more reliable in terms of the level of anesthesia. I know from doing a lot of, sedation or MAC kind of cases that the variability in what is required to keep someone anesthetized with just a propofol infusion is quite wide, whereas I don't find that variability to be an issue with using gas. Not infrequently, I'll use both. I'll use the PIVA technique that I mentioned because the wake-ups are typically a little faster, but it's a kind of a belt and suspenders approach to how much anesthesia they're getting. But I like definitely to have some gas on board. Sometimes I use it entirely just with gas, and sometimes propofol and gas as well.
Does prone positioning ever lead to edema or nerve compression injuries?
That has been described typically more for really long cases. You can get scleral edema, definitely for longer procedures. Ones that have more fluid shifts, definitely more of a risk. And also one of the other considerations is whether or not to extubate at the end of a long procedure due to edema around the tracheal tube. So for those ones, then this would be really long surgeries, not the ones we're talking about here. So it's not been a consideration for these types of surgeries, and haven't seen much in the way of scleral edema at all for these.
Yeah, well, the normal procedures we perform for laser ablation or tumors are in the range of 4 hours, but some of the gene therapy protocols that I've looked at and been involved in designing can be many hours, 8 to 10 to 11. So careful padding and positioning, and any procedure that's 10 or 12 hours for some of these gene therapy protocols and slow infusions, you will see dependent edema, and so you have to be very careful about your fluid overload and your padding during the position.
I'm glad you brought up procedure length time. We've got a couple of questions related to that, so I'm going to try and combine some of them together. So we've got, is there a maximum time limit for procedure length where prone would not be able to be used? And another question related to specifically ocular pressure. You had mentioned that's not a concern with shorter surgeries. Is there any particular kind of cutoff at which point then ocular pressure would become a concern? So I guess we'll do the general procedure length and then maybe this ocular issue second.
We're always concerned when there's a long procedure. I worry. I mean, edema resolves. That's not the problem, and it's a hard pressure point that could even cause some either a compressive peripheral neuropathy, but that won't happen if you're properly padded. Sometimes those are minor or will recover typically. So I don't think there's an absolute cutoff. You have to successfully accomplish the procedure, and it's going to take as long as it takes. I think I would worry if somebody, would I immediately extubate them? Careful about that. I think it depends on the length of the procedure. This is why that'd be one concern. I think, as Dr. McNicholl has already suggested, maybe you watch them for an hour or two in recovery before you extubate, having them up at 45 degrees or something like that.
Exactly. Yeah, I would be in favor of that. You could also do a leak test, though that it's not 100%. It might give you some reassurance that there's not swelling around the tracheal tube, but yeah, 45-degree positioning, a little extended time, a little more anesthesia time, but that will help to let that edema abate.
Do you ever administer anti-seizure medication prophylactically for non-epilepsy cases?
We don't for the simple laser ablations. I mean, or I wouldn't for a tumor. I think you'd want to be careful. I think you'd have to look at the protocol in terms of the gene therapy. Do you really want another agent being administered in a clinical trial protocol? I think it would. I don't know the correct answer for that.
So I know traditionally your procedures are done in adult patients, but we do have a question about, so I'm not sure if you can answer. How young can a child be for prone positioning for this type of procedure? Do you have any thoughts about that, Dr. McNicholl? I don't know if you ever do peds cases.
We haven't, we don't do them here because we're attached to Children's Hospital Boston, so that's where those would be done. So yeah, I wouldn't really want to comment on how they do it there, but it is a good question. I just
I do. I mean, my colleague Dr. Skellig Stone does these all the time in children, so I think it's certainly very feasible. He does laser ablations in these children almost every week. So it's certainly feasible.
Okay. Are the bolster bumps under the torso always placed longitudinally, or could you place them horizontally? And someone was asking, are those softer gel bumps that were in the picture?
I always place them longitudinally. That's people. That's just preference, but I always place them longitudinally. They're gel bumps. One of the things you do want to consider is you want them high enough because you want the head to sort of fall down. Occasionally, with if you have it's actually a bigger, fatter person is a little easier because they've got more girth, and their head drops a little bit easier, which sometimes makes the clearance and everything inside the bore of the magnet with the ClearPoint tower more favorable. Some of it depends on the inner diameter of your magnet, how big it is. You can sometimes run into issues with the height of the tower. But
Okay, this is a very specific question. Would you use the same approach and expect similar outcomes if the procedure were to require initial supine positioning, then a change to prone positioning in the case where supine position would allow better access to some brain structure while prone better for the other, for example, putamen and caudate? How much additional time would you expect that repositioning midway would entail, ensuring the ET tube is still in place?
That's almost twice, it's almost two separate procedures, basically. The only time saving would be you don't have to induce anesthesia, but you'd have to take them out of the pins, reposition the head ring. You would basically double the time to do a separate ClearPoint from in a prone position to a supine position, I think.
Okay. We have a question related to not using the diagnostic MR versus using the IMRIS where the magnet is moving. I know that that's not your workflow, so I can answer for this person. Yes, you can do prone procedures in an IMRIS. It's just a little bit of a slight modification. And then the last one to close it out, is prone positioning any less safe for the patient than supine?
From a neurosurgical, I mean, prone position is always a little less safe than supine, mostly due to anesthetic considerations. I mean, not from a neurosurgical procedure kind of consideration. That's always my concern. And I think that, Dennis, what's your thoughts on that? It's always a little.
I'd agree. I mean, if everyone could choose supine positions easier because it's more natural. However, we accommodate all those things, and just with the attention to detail, I think it's certainly something you can accomplish and accomplish safely. The positioning issues you can't get around. So, good padding and good attention to detail with those things are just the risks we try to manage. And I think it can be done safely that way too.
Excellent. Well, thank you both for your time this morning. This was wonderful, and we really appreciate you sharing your expertise with everyone on the call. Thank you so much.
Thank you.